Hi everyone, I'm Matt Parry, a urology reg from London, and between 2017 and 2020 I spent some time with the National Prostate Cancer Audit doing a PhD out of programme. During this time I was involved with data analysis for the annual reports as well as involved with the outcome reporting programme. So the remit of my talk is to talk essentially about the outcome reporting programme. So to give a bit of an overview, I'll start by talking about the development of the outcome indicators that we use and developed, and then I'll go on to talk about how those indicators have been used by the NPCA to assess variation, and then touching a little bit at the end on how those indicators have been used for research purposes as well. So a bit of an overview about the data. So it all starts with National Cancer Registry data. So that supplies information on men newly diagnosed with prostate cancer in England and Wales, provides us with baseline data about Gleason score, PSA, and TNM, as well as other important variables. We're able to then link that at patient level to hospital episode statistics. So HES is an administrative hospital database, which provides us information about which men with prostate cancer go on to have radical prostatectomy. So that's done through procedure codes in HES. We're also able to link to the National Radiotherapy dataset, so that provides specific information about what type of radiotherapy people are getting, as well as the dosages of that radiotherapy. And the final piece of the jigsaw is the Office of National Statistics, which provides mortality data. So as we all know, there's quite a protracted natural history of prostate cancer. So we haven't really used any mortality outcomes as of yet, but that is very much on the horizon as the data matures. So in terms of the indicator development, these are the two landmark papers from the NPCA essentially, and all the work has basically stemmed from these two papers. So not to take any credit away from Aaron Sajentharan, so he was the clinical fellow before me and very much the driving force behind these two papers. So essentially, in summary, it's a way of measuring urinary complications after radical prostatectomy using HES data. So that's the top left, and then also measuring genitourinary or gastrointestinal complications following radiotherapy, and that's the bottom right paper there. So a bit of background as to how those indicators were developed. So this was roughly performed in about 2014-15, right at the start of the audit, and we used historical data, routinely collected data from between 2008 to 2012. And essentially we used a transparent coding framework based on procedure codes in HES, and we used a technique that we termed forward coding and backward coding, which essentially allows us to capture the idiosyncrasies of coding practice. So forward coding was essentially us going through all of the procedure codes in HES and identifying upfront specific procedure codes that were relevant to either post-operative or post-radiotherapy complications. And then what we termed backward coding is in that patient population of men having either surgery or radiotherapy, looking at the most popular procedure codes within those episodes of care and seeing if there are any other relevant procedure codes that might be relevant to post-operative or post-radiotherapy complications. So giving specific examples for surgery, procedure codes related to stricture surgery or incontinence surgery. And for radiotherapy, we were able to add on to the genitourinary complications with gastrointestinal complications as well. And that focused more on lower GI endoscopy, so colonoscopies and sigmoidoscopies. So we didn't just want to rely on procedure codes for this. We wanted to make sure that they were as valid as possible, to make sure they were as robust as possible. So we wanted to see whether there was any concordance with the diagnosis code. So the thing with HES is they can capture procedures, but also diagnosis codes. So we were able to look at the men having procedures for urethral strictures or incontinence procedures and look to see whether there was a relevant diagnosis code in that same episode. And we found that there was a very high concordance with diagnosis codes. So men having, for instance, a procedure for a urethral stricture post-prostatectomy, more often than not is they had a diagnosis code specifically for urethral stricture, and that just added an extra level of validation to the indicator for surgery. For radiotherapy is a little bit different because for gastrointestinal complications specifically, men have colonoscopies for all sorts of reasons and may be unrelated to radiotherapy. So for that indicator, we made sure that it was coupled with a diagnosis code. So for GI complications, we made sure that there was a code similar to radiation proctitis within that episode. Again, added a validation, further level of validation to those indicators. Finally, we were also able to show that there was appropriate association with our indicators with specific patient surgical and radiotherapy characteristics. So an example of that is you'd expect as patients get older, they're more likely to get complications, and that was borne out in the data when we stratified it by age, and that was also the same for comorbidities, socioeconomic status, and increasing stage. So just a general slide here about what makes a good performance indicator, because we really do want to make sure that these indicators are robust as possible, particularly if we're then using them to give hospitals outcomes and start to compare outcomes between hospitals. So there's four main things that make a good performance indicator. I think Jan briefly touched on this in his slides. So validity, we've certainly got validity there because we've shown an explicit coding framework, and we've got a number of ways of making sure that we've shown them to be valid. Second point is are they fair? Can you use them to compare providers? And so the most important thing there is we were able to risk adjust to allow for differences in case mix. So we were able to adjust for age, stage, socioeconomic status, and comorbidity. Third point is it technically feasible? So we were able to define a specific population of men with prostate cancer using the cancer registry data, linked to HES to identify people having surgery, linked to radiotherapy to identify specifically people having radiotherapy. So certainly we've got a defined population. We can adjust for case mix, and also we can show that we can measure clinically relevant outcomes, which is vital. Fourth one is, do we have statistical power? But with 40,000 new diagnoses of prostate cancer every year that's captured within our data sets, we certainly have sufficient population size, and with centralization increasing the numbers of patients having radiotherapy or surgery at specific centres, we're starting to get really big numbers at specific centres, giving sufficient population numbers and also sufficient number of events to allow us to start to compare providers. So I've given a bit of a background about the toxicity indicators. So that's the genitourinary and the gastrointestinal toxicity indicators for radiotherapy and surgery. But a really vital point of the National Prostate Cancer Audit is we also collect patient-reported outcome measures. So since 2014, every couple of years, new waves of patient surveys are sent out to men 18 months after diagnosis. So we really get a feel for functional outcomes for these men, specifically related to urinary function, bowel function, and sexual function. So between the two, between the toxicity indicators in hospital utilization and procedures, we've also got the patient functional outcomes, and together that provides a real breadth of coverage for all outcomes. So just a general slide here about all of the hospital level performance indicators that we can use together. So we now have urinary toxicity after surgery. So that's with the toxicity indicator described earlier. And that's we use a cutoff of 2 years after surgery, and also using the EPIC 26 urinary function domain. Equally for gastrointestinal toxicity after radiotherapy, in a similar way, 2 years after radiotherapy is the cutoff for our toxicity indicator, as well as using the bowel function EPIC 26 domain. We're also able to capture sexual function after radiotherapy and surgery using the PROMs as well. Now, given the fact that procedures for reduced sexual function are very rare, we haven't been able to develop an indicator in HES for that, but certainly we're reliant on the PROMs for sexual function. And the final point is specifically for surgery, we're able to report on 90-day readmissions after surgery. And this is because HES is so good at highlighting procedures men get, the dates they have them, but also the subsequent admissions to hospital after that. So it's quite easy to then measure 90-day readmissions and turn that into a performance indicator as well. So this is an example of how we started the outcome reporting. So essentially this is an example of the funnel plots we use. So each of the performance indicators are then transferred over to producing a funnel plot. And so each dot represents a different treatment center for surgery or radiotherapy and provides an overall outcome measure for that center. So this is an example of gastrointestinal complications following radiotherapy. So each, essentially, if a center is outside the funnel limits, that means that it has a complication rate greater than 3 standard deviations away from the mean. And then this is fed into our outlier process, whereby each centre gets a full breakdown of their data, which they can perform their own sense checking on and make changes to practice where and if appropriate. So that's the website there for the National Prostate Cancer Audit, where anyone can log in and find out their specific provider results. So you type in the hospital that you work at, and it will tell you a full breakdown of the whole range of hospital level performance indicators we produce. So a few considerations. So the aim is not necessarily to rank hospitals, but to assess if performance is further from the national average than would occur by chance alone. And we don't adjust for differences in surgical or radiotherapy practice, as this can inappropriately mask variation in outcomes. And a specific example of this is variation in IMRT use across the country, and we don't want that to mask variation that we see. We have found that toxicity indicators do reduce the likelihood of misclassification bias, which is a real bonus for the data type that we use. As described earlier, we have a standardized coding approach for grading toxicity, and we are not dependent on individual clinician reporting. So it really does maintain an objectivity in the complication reporting. And finally, we have found that there is an agreement between PROMs and our indicators, which further adds to their validation. So in terms of the impact of the outcome reporting programme, we have found it to be quite positive on the whole. It has led to a challenging of existing cultures and beliefs, and it does allow centres to be aware of their outcomes, which they may not have been previously aware of, as well as providing objective data in order to make changes. It's also highlighted the need for quality assurance across the whole surgical and radiotherapy care pathway, and the annual QI workshops have identified several areas for improvement. So specifically related to the peer review process, allowing centres to learn from each other and gain feedback. Specific examples from radiotherapy centres have made changes with respect to contouring, dosimetry and target localization, and regards to surgical centres with respect to training cases and maintaining good functional outcomes. So finally, a comment about communication and team working. As with any quality improvement, requires a huge effort from very large multidisciplinary teams. So moving on to talk a little bit about how these indicators have been used in research. Over the last 5, 10, 15 years, there's been huge advancements in techniques and technologies used in both radiotherapy and surgery. So the data we have has really allowed us to compare outcomes between different treatment strategies, and that's specifically in a real world setting, so outside the tight constraints of a clinical trial. So this is one of the first papers that we did. This is by Aaron. So again, like I said before, he was the fellow who predated myself. Using those genitourinary complication indicators, we were able to compare the different modalities of surgical practice. So we were able to show that there was a statistically significant difference in treatment modality. So a difference between robotic assisted, laparoscopic assisted, and open robotic prostatectomy. We were also able to use our PROMs to do a similar paper. We did show some statistical difference in the PROMs for the different treatment domains, but they didn't reach the threshold for a clinically relevant difference. A paper we published last year in BJUI, this was looking specifically at incontinence after radical prostatectomy and the use of incontinence surgery. So I won't go into too much detail, but this is a graphic from the paper which showed specifically the men with a low urinary incontinence score after surgery. So that's men with an EPIC 26 domain score of less than 25, which we defined as a severe urinary incontinence. We were then able to stratify that by urinary bother. So this is from the EPIC 26 and how men rated their urinary bother. And what we found was, although all the men who were having incontinence procedures, they were reporting a big problem with their urinary incontinence. So the right men were getting incontinence procedures. However, there were a vast amount of men who were living with a large problem with their urinary bother, with severe incontinence that weren't going on to receive incontinence to surgery. So this was just highlighting that there was a possible unmet clinical need for incontinence surgery post-operatively. So moving on to radiotherapy, we were able to compare different radiotherapy treatment modalities. So This was done a few years ago now, so now IMRT has very much become the gold standard for radiotherapy in the UK. But we were able to show that IMRT versus 3D conformal radiotherapy, that there was a significant difference in the toxicity rates. We're also able to show this for hypofractionated radiotherapy, showing that there was very little difference in toxicity rates, which was important as people moved towards hypofractionated radiotherapy, less patient admissions to hospital for the radiotherapy episodes, but no, there wasn't a worry that conferred worse toxicity. We were also able to show that with the PROMs, which again shows good agreement between our PROMs and our toxicity indicators. And then one final slide on the research, we were able to compare whole pelvis radiotherapy to prostate only radiotherapy to show that there was no real difference between the toxicity there. This was for the PROMs measures and also the toxicity measures.
Sorry, we've just got a minute there left. Thank you.
This is just the summary slide now. So in the summary, outcome reporting can support quality improvement. This standardized coding template allows it to maintain objectivity, and the PROMs add further depth to that. Can be done at low cost, and this is good for what it can deliver, which is quite substantial, but must be done robustly, and this does take many years to develop good, robust indicators. And this continues to be iterated as we get feedback from trusts. And finally, we can use these indicators to produce high impact, real world population based research. So thank you.